Welcome to the Paediatric IBD Digest, the podcast focused on paediatric inflammatory bowel disease, Crohn's and colitis in children and young people.
We, as your hosts, Dr. Tracy Coelho and Dr. Chris Bakewell, discuss clinical care and emerging research on select topics to support families and professionals alike. Please remember, the views shared are educational and do not constitute medical advice. Hey Chris, I don't know about you, but I think I might be a little out of my comfort zone on today's podcast.
Oh, go on then. I'll bite. What's the problem today, Tracy?
Well, not a problem exactly. I must say more of excitement, with a side of jitters, because today we've got an adult gastroenterologist on our pediatric IBD podcast.
Okay, I'm with you. So what you're saying is we maybe need to be a bit more grown up for this one.
Exactly, and we have invited someone who is a major figure in the adult IBD world, here in the UK and internationally, the chair of the BSG IBD committee.
Yeah, no, that's actually really important, and jokes aside, I think we've stressed this on the podcast before, but us paediatric gastroenterologists really should be working a lot more closely with our adult colleagues. So, in that vein, it's really great that someone from the BSG is so interested in sharing their clinical insights.
Absolutely. So I think we'll park the centile charts for today instead. She's bringing something pretty serious. Clinical trials in IBD. You know, the ones adults always seem to get first. Adults at the top table with fancy new treatments and kids at the little table with plastic cutlery.
Yeah, all right. We'll try our best not to be too bitter, but, maybe at the end I'll ask her if she has any spare risankizumab.
Yeah, absolutely. So if it wasn't enough, we are even going to wade into the role of placebos, safety, ethics, and how to explain it without sending families into a panic mode.
Right then, I guess we'd better roll out the red carpet and give the warmest welcome to the current chair of the BSG IBD committee, Dr. Shahida Din.
Buzzing in excitement with a flutter of nerves dancing within as the feast of academia is about to begin. Ladies and gentlemen, with great pleasure we usher in the BSG Empress of the IBD discipline, the legendary, the one and only Dr. Shahida Din. Shahida, welcome to the pIBD Digest. We are really super excited to have you on the podcast.
I'm excited to be here too, and Tracy, that is such a lovely introduction.
So, Shahida needs no introduction in the adult GI world, but for the sake of my pediatric audience, let me tell you a bit about her. Shahida, please feel free to step in and fact check because I have outsourced your profile to my most trusted non-human friend who is occasionally known to confabulate and hallucinate. So, Dr. Shahida Din is a consultant gastroenterologist at the Western General Hospital in Edinburgh. She specializes in adult inflammatory bowel disease and has led national work in the UK, including IBD cancer surveillance, among several other things. And beyond her clinical work, she's a leader in education, research, and policy, shaping how we can care for people with GI conditions across the UK. Ooh, all silence. Fact-checking in progress, I suppose.
It's either so inaccurate that there's nothing to say or very flattering.
I think it's very flattering and paints me in a much more glamorous position than I think I probably am. But that's very kind of you. Thank you very much.
You've been the chair of the IBD working group for the BSG, I think I read since 2022, so you've had 3 years in now. Firstly, congratulations. It's obviously an important role within adult gastroenterology and IBD. Would you, for our audience, be able to talk us through your journey into becoming the chair? Did you always see yourself as someone that would be leading on IBD nationally, or perhaps more of a happy accident?
Yeah, no, thank you for that. And so I'll just correct you and say that I've only been the chair since June 2024. So I only took up the chair position in 2024, but I have been on the IBD committee since 2019. So I've had a number of years actually being elected as a committee member, and I've really enjoyed actually the collegiateship within the committee. The committee is made up of gastroenterologists, surgeons, paediatricians, pharmacists, specialist nurses. We don't unfortunately have dietitians or psychology representation, but we do ask for their help if we've got any specific projects. So, I've been in the committee for a long time, and as I say, I really enjoyed being part of that collegiate working that we have. And it just introduced me to a whole new ecosystem of IBD colleagues that I wasn't aware of necessarily. And I started my journey, I guess, when COVID happened at the same time. And so it did lead to a lot of change about how we delivered meetings, delivered education, led research work. And I think for me, that was a period of real enlightenment, actually. And I did a number of things, COVID-related studies, presentations, did a lot of work around improving IBD care, leading some projects myself, but being part of other projects. So I found it a very, very, very valuable experience. And I guess if somebody does have the time to do committee work in an area that you're interested in, it is good to try and do that. Obviously, it has an impact on your work itself because it's additional work to what you do, day to day.
Sounds like you've been prolific. So I guess then taking one step further back, let's talk about gastroenterology. What drew you to the specialty? We as paediatricians have our own reasons for getting involved in this kind of work. But as an adult gastroenterologist, is it the patients, the colonoscopies? What's the attraction?
Yeah, so it's interesting you say that, in that often you're inspired by people who you meet in an early journey. So as a medical student, I trained in Dundee, and I think it was in about my 4th year, I met 2 really inspirational senior gastroenterology registrars who are now very famous. Professor John Dillon, who's Professor of Hepatology in Dundee, and Dr. John Anderson, who's a specialist endoscopist now based in Cheltenham. Both of them are very senior trainees when I was a medical student, and they won't remember me, but they had such a profound impact on making gastroenterology exciting. And that's all it takes, is somebody to inspire you. And they showed me the breadth of sort of conditions that gastroenterologists can look after. And you can go from luminal disease, you can go from looking after the friends of the gut to the pancreas and liver and gallbladder. But it's such a wide variety of processes that can affect the gut. So functional, autoimmune, genetic, cancer, infection, really anything that you were interested in, you could focus it on the gut. So for me, that was the best specialty ever to be able to focus on as I finished my training and then tried to get house jobs.
That's great. So being the BSG IBD chair sounds like really a huge job, balancing clinical work, family life, and everything that's in between. So what's the most rewarding part and what's the most unexpected challenge?
Yeah. So I think, as I said, the most rewarding part is actually meeting people who have different perspectives and the opportunity to learn from them. I think every encounter that you have in life is an opportunity to learn from somebody. And that was said to me, somebody who was very dear to me, who sadly passed away very recently. Take every opportunity in life to learn. And that's the best I could ask for. As a committee, we've just had our annual strategy day in Edinburgh last week, and I'm really, really privileged to have such an amazing group of people to work with. They all inspire you. They all focus on different aspects. And in some ways, I think we're actually going to be a victim of our own success, because we are quite an effective community, and we produce lots of useful guidance and guidelines and support each other. And I think, we're fortunate to be in that position that we're being approached by many different organisations to actually get involved in the work that they do and we do. So I'm slightly worried that we're actually becoming too popular at the minute. But I guess that's a benefit, isn't it, of having excellent people to work with.
So despite your amazing credentials, there are another reason why we've asked you to come on the podcast today. Your recent papers, so end of 2024, I think they were published. There were 2 papers, both looking at the harms of placebo in IBD drug trials. That's one paper on the induction of remission and one paper on maintenance therapy. Can you set the stage for us? Why are placebo-controlled randomized trials considered gold standard, especially within IBD trials?
Yeah, no, and thank you for asking me to come and speak this on the podcast. This week actually is the anniversary, so the first anniversary of the papers being published, and so that's something I'm very proud of. I hope that the authors that I worked with and the colleagues that I worked with are proud of that too. So I guess if you think very simply, a randomised controlled trial is an experiment to ascertain the benefit or risks of a new treatment, which we often consider to be the treatment effect or the potential safety of a new intervention. To minimise bias in that kind of experiment, you're randomly assigned to either a new drug or a control, which may be placebo. Sometimes it's not. Sometimes it's an active comparator. And that serves as a benchmark. And it's done in a blinded fashion so that often the people that are intimately involved in running the trial, so the researchers, the nurses and the patients themselves or the participants, they don't know which treatment they are receiving. And that allows you to control for bias as well. But essentially what you're trying to do is just check to see if this new drug or new intervention is actually going to have an effect and it's safe. And I guess the audience here is hopefully a learned audience who either have IBD themselves or are working in the field of IBD, and they will know that to actually have new drugs approved by the regulatory authorities, and that would be, the FDA in the USA, the MHRA in the UK, or the EMA in Europe, you have to go through a process of demonstrating that a new drug is effective and safe. I guess the reason placebo trials are considered to be the gold standard in research is because of these factors, the reduced bias, reduced confounding factors, and it produces a context that allows researchers to draw reliable conclusions between an intervention and its outcomes. And that rigorous design can then be reproduced, and it's something called, it has internal validity of the findings, which means that the results are likely to be true and applicable. And I guess that's why that's important. And I think we must remember that at a time when we had no drug therapies for treating IBD, this was really important trial design to determine these new drugs like infliximab or adalimumab or vedolizumab, ustekinumab, the new drugs that we see were all effective in that manner. However, there are ethical principles that guide how we design trials. And you might be familiar with them being paediatricians. You have an equally interesting history about how you've managed to minimise the placebo use in paediatric trials, and their judicious use is now being supported. Would that be a fair comment in that it equally applies to paediatric patients and adult patients?
Absolutely. I mean, you mentioned it in your paper quite early on, in both papers quite early on, about, the paediatric stance, and the Porto group, set out their own stall on it, very much advocating for a minimised or justified use of placebo trials in children.
Absolutely. And the literal meaning of the word placebo, as I understand, is I shall please, which also happens to be my strategy with my co-host to keep the show running smoothly. So, shifting gears a bit, now many patients hear the word placebo and think sugar pill. And so what kinds of harms did you and your team uncover in your analysis of your paper? And were you surprised by the scale of or the type of placebo-associated harms? And did it confirm what you had actually suspected from your clinical experience?
Yeah, and I wonder if I might, just before I answer that question, just be able to say that we do have guidance available that allows us to use placebo, in an appropriate and safe manner. And I just wanted to quote the current declaration of Helsinki that was updated last year to say that, the declaration of Helsinki restricts placebo in two scenarios. One, when no proven intervention exists. And if you think about the field of IBD now, we've got multiple interventions that are effective and thought to be low risk or safe. And then the other one is when it's scientifically justified and participants are not exposed to serious or irreversible harm. And I guess the tension is that we do now have evidence with the work that we've done that participants are exposed to harm, and it's not always irreversible, which is what was, I think, incorrectly surmised before. So I think we do have guiding principles about, when to use placebos. But to answer your specific questions, each new study or research that we do, or trial that we do, it always starts with a story, doesn't it? And I guess my story was that just before COVID, I was supporting a number of commercial and industry-led trials, and we randomised many patients in Edinburgh in my local team. And two of my patients particularly became unwell and were admitted, and as part of the trial process they had to be unblinded to be able to deliver safe treatment to them. And both of them were actually in the placebo arm of different trials. And I think that was a kind of full stop moment for me, in that I thought, wow, my patients have actually come to harm through this process. And it's not something that I'd really seriously considered before, because at that time, we'd maybe had 3 drugs that had been licensed. We had anti-TNFs, vedolizumab and ustekinumab. And so I did have a number of patients that had failed all 3 medications, and thought it's absolutely, I think, right at the time that they should then be randomised into a placebo-controlled trial with a drug with a new mechanism of action. But that gave me a time for reflection, and having discussed it with my own local team, I tried to then pursue this a little bit by asking industry and my colleagues what their thoughts were about this. And the automatic answer I got was, actually, there's no harm. And I then also said, well, there is harm. I've seen it in my patients. And that led on to a journey to trying to work out how if we could quantify the harm. So that's how it started. And I think the interesting thing is that when we did look at trials, you're absolutely right, we looked at both induction trials and maintenance trials. So induction trials are short trials that last usually 8 to 12 weeks, and they're trying to induce remission when patients have active disease. And the maintenance trials tend to maintain that remission over a period of usually up to a year, but it can be longer. So what we found is that we'd actually, when we did the systematic review and analysis, for the induction trials, we found that we looked at 47 trials in just under 21,000 patients. 2/3 were randomised to an active drug and 1/3 were randomised to placebo. And we identified that actually, if you're in the placebo arm, you're approximately twice as likely to get worsening of your IBD, serious worsening of your IBD, serious adverse events, serious infection, withdrawal from a trial, and even blood clots. And they're actually fairly major consequences of being in a placebo arm. And remember, it's not the placebo that causes this effect, it's having active disease that leads to these adverse events. And I think, again, I just want to read out what the definition of a serious adverse event is, because I think in the context of how we treat disease and see disease, sometimes we can become immune to the symptoms and complications our patients have, because we sadly see them so frequently. But the serious adverse event defines any adverse event that results in death, is life-threatening, requires hospitalisation or prolongation of an existing hospitalisation, or results in persistent or significant incapacity or disability. It's actually a fairly serious context, when you think about it in that manner. And while we didn't drill down into the very specifics, I think just even the headlines are actually, for me, they were quite startling. And I don't think I realised, certainly, the level of harm that may have occurred to some patients. Because remember, not everybody will experience an adverse event. And you must also remember that even the new drug or intervention might cause an adverse effect because it's been ineffective. Not all new drugs work in everybody. And we had similar data when you looked at the maintenance trials. There was 45 trials. There was just under 60,000 patients. And again, we saw worsening and serious worsening of their inflammatory bowel disease, serious adverse events, and more people withdrew from the actual trial because of these adverse events. So it's trying to help people understand that, when we've quantified the adverse events that we see when people are randomised to trial, it is there, it's real. It's not a figment of our imagination, or it doesn't just affect a small amount of people. It actually does occur. And I think before we'd done this work, there had been other studies that had looked at the adverse events in a trial, and some of them had come to the conclusion that there was no overall effect. And we see the same thing. So if you compare just the total adverse events between drug and the placebo arm, you don't necessarily see any distinction there.
Yeah, that was an interesting finding that I picked out, because of the headline. If you go through the findings at the top one for both papers, I think, is that the overall adverse events are the same. So you could stop it there, end your conclusion, and say, it's all the same. But if you read on in your papers, you very clearly, lay out that actually that hides the underlying evidence, which is if you don't treat disease, you get consequences. And I was just going to ask, obviously the majority of our audience will be interested in paediatrics, given we're a paediatric IBD podcast. The papers that you've looked at, many, many patients, the vast, vast majority will presumably be adult patients for ease. That's just who tends to be in these clinical trials. But in your opinion, I know you're not a paediatrician, but there's no reason to suspect that those outcomes would be any different in a paediatric cohort.
No, and I think you're absolutely right. In a paediatric cohort, so I did transition clinics actually. I've done them for a number of years with my colleagues in Edinburgh. And I always get a sense that they worry about the consequence of active disease more acutely, because I guess if a child is unwell, it limits their growth potential, both mentally, physically, sexually, and it limits their maturity. It has an impact on their education. Sadly, some of my patients in the young life, when they've had active disease, have not been able to go to school consistently, so they miss out on education. But they also miss out on other aspects of life in having confidence of who they are. And it's really sad when you hear that patients have bowel symptoms of urgency or incontinence that actually stop them then having an active, for example, school life or just normal life or social life. And I think when I hear those symptoms, on behalf of my patients, I get really upset. And you've only ever had to have gastroenteritis yourself to know how bad severe cramps can be. When you've got bowel urgency and diarrhea, you just feel rubbish. So can you imagine having those symptoms all the time and not really getting relief of them? I think for me, that's just, an astounding thing to think that somebody would have these symptoms for a long period of time.
Yeah, absolutely. I mean, you obviously wasted in adult medicine. You'd make an excellent pediatrician. That is, you've hit the nail on the head. This is for us, we deal with a range of patients with a range of different ages, from the very young to the teenagers. But of course, in all of that, it's a very critical part of your life. You're setting up to become an adult, whether you're 5 and have very early onset IBD, or whether you're 16 and about to sit your GCSEs and it completely scuppers any chance, of getting into university. So for us, as with you, I'm sure, this is a hugely important thing to get right.
Can I maybe just say something that maybe we don't appreciate the impact on adults in that manner, in that, when young adults come to you in clinic, or just, just adults of any stage of life, when they tell you that they stop going out because they are so worried about the bowel symptoms. And COVID was a really difficult time for some of my patients because public toilets were closed across the country. And so patients, as well as being isolated themselves, us telling them that they shouldn't come to hospital, not being able to work, then for their hour of exercise a day they were allowed to go out, they didn't necessarily want to go out because access to toilets was limited. And people, I don't know if children do this or parents do this, but I have lots of patients who have toilet maps. They map out where the toilets are and they construct their life and their journeys planned around toilets. And I think that is really... that must be so difficult. My children laugh at me because I coffee map. So I plan my journeys based on coffee shops. And they think this is slightly hilarious, but that's an enjoyable thing. Can you imagine how having to toilet map? And I think that aspect of life, and being British, we're not very good about talking about these things. So we shy away. So I think there's a huge impact on adults, on their confidence, their ability to work. I have patients who have sadly missed out on job opportunities just because they haven't been able to control bowel motions. They've lost income, employment, they've lost partners, they've decided not to have children. So I think there's a huge impact on overall quality of life that I think are not measured in trials. And as medical professionals, we're guilty of not asking our patients regularly either. So it's a huge impact.
Yeah, I think we obviously could learn a lot from each other. We're pretty rubbish at talking about the other things.
Yes, I would totally agree. These sort of things are often overlooked in our clinic consultations. So Shahida, if we change direction for a moment, I would like to ask you, clinical trials in IBD are often industry sponsored. So how do you see the balance between industry involvement and independent academic research?
Yeah, thank you for that question. I would see it as a complementary partnership, and I think there's a real opportunity for both industry and independent academic researchers to work together. I think what I'd like to see is actually closer alignment of our main objectives, which is to improve patient care. And industry often have the resources to investigate in new drugs, new mechanisms of action, or new formulations of drugs. And I guess independent academic researchers often can evaluate the clinical need that we have and the evidence gaps that we have. So I see it as being very complementary, and that's what we've seen is that, some of the very major blockbuster trials that we've seen have come from collaborations between industry and academic partnerships. So I think they work well, and I continue to support both because I think they both have value. And whilst I do have some concerns about placebo trials in moderate to severely active IBD, for which we have very good, effective licensed therapies, there will be placebo still will remain important, where we have uncertainty about whether a new drug or intervention or the context of a specific disease such as mild Crohn's disease or fibrotic disease, where we don't have very good treatments and we're not sure that the standard treatments do make these patients better. So I think I see it as a partnership, and I hope that continues.
I'm sure that will resonate very well with our patients and families listening to this podcast. Patient is, after all, the boss, and they make the choice. We can only help them understand and make the right choices. So on those lines, which you've already alluded to, can I ask, for patients listening, how can they be reassured about the integrity of trials when industry is heavily involved?
Absolutely. I guess it's helpful for patients to know that any study involving human subjects goes through a really rigorous process and is, assessed for compliance against several metrics, and that includes novelty of what they're trying to study or research, addressing a clinical need, ethical review of the study itself, and the potential harms that can come to the patients. And I'm constantly impressed by the number of rules and regulations that industry have to comply with to run successful trials. So I think I want patients to be reassured that there is a rigorous process where trials come to that stage where they're able to start recruiting patients. And I guess we must remember that it's only because of these trials that we have these effective therapies that we are able to use so successfully. And whilst, as I say, there are now a disease, and our knowledge of disease evolves, or we understand the impact of active inflammation, and that, I guess, leads to the concern that we have of placebo use, is because patients have active disease have long-term consequences. They can be at risk of cancer or hospitalisation, needing surgery, or needing more treatments over their lifetime. But if we didn't have the trials and the way that have been run before, we wouldn't have been able to identify that some therapies are actually not safe, or they cause worsening of IBD too. So there's always a balance to be considered, isn't there? Is that, what is the risk and benefit, and how does each patient perceive that? And as a patient myself with different conditions, I might be happy to be involved in a trial if I knew that it was going to provide different treatments or different solutions to the way care is run, as long as I knew that I was being looked after, and that any harm that I may experience is going to be temporary or reversible. And that's a conflict we now have, isn't it? Is that with the work that we've done, we've shown that some of these harms are potentially very serious for some patients. And having that data, if you think about the work that we've done in the data, we've shown the flip side of that is if we give people effective treatment, then they have less worsening of disease. The disease gets better, they're less at risk of infections or less at risk of adverse events and blood clots. And it's interesting that, having discussed the papers with some patients, they've actually been encouraged to continue using their treatments because they know it makes them better. And so there's always a balance and risk that needs to be considered.
That's very insightful. I'm sure all our patients will find it really reassuring.
So I was going to ask, what do you think all of that means for how we design IBD trials in the future? Should we be rethinking the use of placebo arms? It sounds like it. I mean, maybe there are some contexts where it's still appropriate, but largely speaking, should we move towards head-to-head? Where do you think we should go?
So I think it'd be really helpful for the community as a whole just to think about how we do trials and the ethical process that govern us. And one of the aspects that I've realised on this year, this journey over a year, speaking to different industry global leaders or people who are involved in trials, is that we seem to have forgotten or not really appreciated this concept of clinical equipoise. So clinical equipoise means that there's uncertainty about whether treatment is better than the current treatment or better than nothing. What we are clear about is that placebo, we're not uncertain anymore that people should be left up with untreated disease. So we shouldn't be really testing the concept of placebo. And I think if you are going to run a trial, we need to think really, more deeply about whether the question that we're trying to address. And I think that's something that the clinical community should have the courage to uphold ethical principles and have a constructive dialogue with all the stakeholders involved. And that includes the regulators, the ethical review boards, the patients and patient charities who are involved, in trial support, and also the clinicians and researchers and everybody else in the industry. So I think what I'd really like to see going forward is a roundtable discussion. I don't think I'm important enough or relevant enough to be able to lead that on my own. I probably need to have some support from people around me. But I think what I've seen in the last year certainly is that people are willing to talk about this more openly and acknowledging that the work does demonstrate that placebo causes harm, and how do we move from that. And I'm really fortunate to be in the UK IBD community, and that there are a number of people who are leading alternative trial designs, or thinking about what statistical modifications that could come in, how we might use data that we already have to inform future trial design. And I guess my disclaimer is that I don't design trials at all. That's not my skill set. But we do have very clever people in our community, both locally and worldwide, that I think will be able to take this forward. And I hope that I get a chance to work with someone.
Sure. I mean, it sounds like it's a very good step towards clinicians educating themselves about, how these trials are run and how we should be consenting our patients. For the patients themselves, because there are still going to be trials that have placebos, there are ongoing trials that are recruiting. Some might worry that they're about to get a placebo. For those patients that might be listening, or parents of patients that are listening, what would you want them to take away from the research in general about safety and overall participation in clinical trials?
So I guess the important thing to take away is that thousands of trials have been run across different specialties across the world. And with the ethical principles with which these trials are run, patients are looked after. And we do, want to have our processes in place that look after patients. And I guess, like me as a clinician or a researcher, I would always introduce a trial to a patient that I thought would overall give benefit to my patient. As I said, if you remember at the beginning of my patients did have more active disease, I still was keen for them to consider a trial because they'd already had a poor response or lost response to the current available licensed therapies. I didn't necessarily have any other avenue for them to explore apart from being randomised, into a trial that gives them a new mechanism of action. So we will always have a role for placebo-controlled trials. I think we just need to make sure that our monitoring processes are robust, we look after patients, and think about whether alternative trial designs, such as an adaptive platform trial where you can switch people between different treatments that are available, might be a potential solution. And we've certainly seen that through COVID. I don't know if either of you were involved within the COVID trials, but when we had COVID, we were really uncertain about whether steroids or other immune suppressants or immunomodulators would be helpful in the context of people being very unwell and septic. And so they had a number of trials where they randomised people to one treatment arm or the other, and if they didn't improve, they got moved on to a different treatment arm. So I think there's lots of things that we can do to continue looking after patients and supporting them in trials, encouraging them to be part of trials, and also then making sure that the processes are in place to look after them. So I'm not saying that we should stop doing trials. I think trials provide such a huge benefit overall, to industry, who then invest in more, drug research, which is really important to forward medicine as we see it today, and for patients to get access to new therapies, for therapies to be designed so that it can be more widely available to the global IBD instances that we're seeing across the world. But I think there is a need to move that conversation on, because we're intelligent people, so we should be able to take in consideration what we have achieved, what the data is now telling us, and lead that discussion forward, and to say, actually, there now needs to be an iterative process where we learn about how to do trial or design trials or do trials in a different manner that looks after our patients, but also answers the scientific questions that are being posed.
I'm sure you have drawn a very clear sketch of all this, but to circle back a bit, in IBD we have seen an explosion of new biologics and small molecules. Do you think the traditional placebo-controlled trials, do they still have the same place that they once did?
So I think the context is important. So I guess the work that I did focused on moderate to severely active luminal IBD, such as Crohn's disease and ulcerative colitis. I think within our cohort of patients, there will be certain instances, for example, when patients have mild terminal either Crohn's disease with a few aqueous ulcerations that we see either on their endoscopy or capsule endoscopy, we don't know actually if they need to have more stronger treatments like the biological small molecules, or whether they could be solely managed with dietary manipulation or steroids, on an intermittent basis. For example, for fibrosis, we know that for people, up to 70% of people who have terminal eye disease will end up having fibrosis in their lifetime. And so if the end result here is fibrosis, I don't think I've seen any data to show me that the current anti-inflammatory drugs that we use can reverse that process. So for these patients, is it then reasonable to randomise them to a placebo-controlled trial, knowing that the outcome is going to be a fibrotic stricture, regardless of what arm they go into? So those kind of contexts, I think, that we need to think about and when it might be reasonable still to use. And I don't think the IBD community have maybe taken that step yet to think about context-specific trial design and how that inform future practice. I think the other thing to think about is when you have patients who are newly diagnosed with the disease, we're now beginning to realise that there's maybe an early window of opportunity to actually modify their disease course. And if we miss that window of opportunity, we're going to then store up, a number of years of complications and symptoms for our patients. So I think there are specific contexts where you may want to avoid it. And for example, for perianal disease, we don't have any proven therapies as such. There's been no randomised controlled trials with perianal disease on its own. But you can't imagine that anybody would want to run a placebo-controlled trial because perianal disease is so disruptive to the tissue around it, to sexual function, to anal sphincter function. I can't imagine anybody would be brave enough to run a placebo-controlled trial in that context. So I think, it's thinking about the context and the impact on the patient and the long-term symptoms, complications and disease progression that we are putting them at risk of by randomising them to a placebo or no active treatment.
Shahida, I think we have covered a lot of ground. So it's probably time that we shift gears a bit from IBD to non-IBD stuff.
I have no hand in this part of the podcast, I will say. You're on your own.
I suppose that's his non-legal disclaimer. Okay, so we are obligated by a new rule on this podcast, the gut-free round. Formal permission for this from my co-host is probably debatable, but anyway, so a hypothetical offer for a hypothetical scenario, not that it will ever occur in the lifetime of this podcast, given the vacuum in our coffers, which you may have already realized. If we offer you, from the pIBD Digest, a dream dinner invite, who are you going to choose and why? I'll give you options. So the first option is Dr. Beryl Crone, and your dinner with him would be dining on roast chicken and an elemental smoothie served at room temperature because we are going back in time. And you're mainly there to tell him, look, we love your contributions, but the disease really should have had a better name. So that's option one. Option two is Beyonce. You are seated at her exclusive 10-course anti-inflammatory tasting menu, and halfway through she leans in and says, let's duet on my next track, revised version of Single Ladies Put a Ring on It. Instead, it's going to be Gastro Ladies Put the Biopsy Thing on It. And the third option is Ed Sheeran Karaoke Night, a classic pub meal with ginger ale, while belting out his revised greatest hits album from The Shape of You to The Shape of Pooh. And there was a fourth choice, which was brutally censored by my co-host, for a good reason, of course.
Yeah, we tried to stick away from the politics, so you've been pared down with your guest, I'm afraid.
Looks like it's a very tough call. Have you made up your mind yet, Shahida?
If there's any competition, it's got to be Beyonce, hasn't it?
For her work on IBD, presumably.
Absolutely, for her work on IBD and her inspirational, charismatic performances. And because I know that the dinner ladies that I go out with will expect me to say Beyonce.
Yeah, I thought you would go for that. So with that, we come to the next non-IBD segment of the podcast, the Poet's Corner, which I think my co-host may secretly be calling the 3 minutes of suffering.
I'm not a poet. Yeah, that would be fair to say.
Well, I'm not sure about that. He might be secretly loving poetry. So, Shahida, I know that you have composed a beautiful poem. It would be a joy to share with our listeners. Usually, our brave listeners who endure this podcast till the end are either rewarded, depending on their taste, or viciously punished with my usual poetic contributions. So for once, we have a breath of fresh air, which is you.
So that's really kind. So I felt compelled to give you something different, just because I know that my colleagues and friends Marco and Richard Hanson have been on here and they've played instruments for you that are so beautiful. I cannot compete at all. I'm not artistic in that way. So I did write a poem and I asked ChatGPT to refine it for me. And this is in advocacy for the patients who I look after. And obviously I'll say it in my Scottish voice, so hopefully that will help. So it's called Placebo Dreams. I bleed, I bloat, I miss my meals. Dales ruled by flares and toilet deals. Fatigue clamps down behind my eyes. A life of pain the body hides. They gave me hope inside a pill. A blinded test, a studied will. No drug, just sugar-coated lies. While real meds pass my body by. Placebo once made sense, perhaps, when options came in hollow gaps. But now with treatments proven true, why risk a life just to review? I count the days that pass me by, degrees deferred, careers run dry. Love slipped away, too frail to chase, no space for kids, no stable place. Joy shrunk down to symptom apps, toilet logs and flare-up maps. Each plan I made, disease erased. Each hope I had, the gut replaced. Depression hums beneath the skin. Anxiety taps loud within. My stools stay red, the nights still burn. Joints swell and strength won't return. They mark me as a non-response, but I was never given a chance. A subject, not a human face, discarded in a trial's pace. While others heal, I watch and wait. A flare-torn life, a sidelined fate.
Beautiful.
Wonderful. Yeah. She's upstaged you, Tracy, and also clearly rescued our podcast right at the last minute. We felt like, we really went down a rabbit hole with the gut fire round, but, saved at the end. Thank you so much. Perfect. So that sounds like a lovely place to end. Thank you, Dr. Shahida Din, for joining us and giving us your wonderful insights, information on your papers, but also a view of you as a clinician and your empathy towards your patients, which was really lovely. And thank you to our listeners. We hope you'll join us again soon.
Thank you.
Thank you.